Thank you for your introduce, and thanks for the Nanjing Equal Company's invitation. My name is Zhang De Zhi. I come from the First Hospital of Jilin University, and my topic is the procedure of whole caudate lobe microwave ablation guided by fusion images for the treatment of HCC in caudate lobe. Let's start from a case. This is a male patient of 45 years old. Hepatitis C was found to be positive for more than 1 year, and he made misses for 2 months. Physical examination, no positive sign. Etiology, HCV positive. Liver function, CHE and LB decreased. Blood routine, HGB decreased. Coagulation, PT prolonged. PTA decreased. AFP is normal. And MRI showed the tumor located at caudate lobe. The diameter is about 2.1 centimeter. MDT, the surgeon first advised the patient to take the liver transplantation, but the patient has no insurance and very poor, so he can't afford for the liver transplantation. The surgeon second advised the patient take the hepatectomy. And our opinion, the microwave ablation is an alternative choice. The patient evaluate the operative load and cost, finally choose the microwave ablation. A taste systematic therapy and radiotherapy were not recommended. And I searched on PubMed about the caudate lobe ablation, 36 paper published. And this study is from China. 49 patients with HCC in caudate lobe underwent ablation. The first and second year local tumor progression were 18.8% and 27.8%. It's a little higher than the tumor in other position in liver. This study is from Japan, 101 patients. The local tumor progression rate is 12.5 and 22.9. It's also a little higher. So the surgeon said they can cut off the whole caudate lobe, what they call the anatomical liver segmental resection. So I think whether we can ablate the whole caudate lobe to decrease the local tumor progression and have the same effect with the surgery. And let's review the anatomy of caudate lobe. The caudate lobe is small, but it can be divided into 3 parts: spigal lobe, pericaval portion, and caudate process. And the vascular of caudate lobe is very important. If we want to ablate the whole caudate lobe, we should ablate the supply vascular. The caudate lobe receives the blood supply from both port vein and hepatic artery. 68% of caudate lobe have 2 arteries, left and right, and 85.8% of port vein in spigal lobe originate from the left port vein, and port vein in pericaval portion mainly come from the main port vein. Caudate process port vein made it from mainly from the right port vein. So if we want to ablate the whole caudate lobe, we should ablate the left and right vascular. So for this patient, our ablation planning of the whole caudate lobe is first we insert 2 antenna through the left into the spigal lobe. Second, from the right lobe, we insert 2 antenna to ablate the pericaval portion and caudate process. Plan of ablation parameter. Because the caudate lobe and the tumor is small, so we choose the 5 millimeter tips antenna, double antenna, and we planned 4 ablation sites. Up power is 50 to 60 watt. And we use GE ultrasound and magnetic navigation system. This is the lesion display on fusion images. We can see the lesion through the left lobe clearly show on ultrasound. It's hypoechoic lesion. So from left, we use ultrasound single images. We only use ultrasound guided. The first microwave antenna was punctured into spigal lobe around the lesion through left lobe, and then the second antenna. Double antenna ablation together. The parameter tips 5 millimeter double antenna, power 55 watt, time 330 seconds. And then we scan the caudate lobe and lesion from right side. The caudate lobe and lesion was unclearly. And we do not know this area, whether this area had a gastrointestinal tract and where the common bile duct, we cannot identify the position. So we use the fusion images. From the fusion images, we can identify this area is left lobe, and the common bile duct is little distance between the tumor. So we use fusion images for guiding puncture. We insert the antenna through the first and second, between the first and second hilum. Because this volume is very small, so we cannot insert 2 antenna together. So we use a single antenna. The first ablation site was located at caudate process. Parameter tips 5 millimeter single antenna, power 60 watt, time 390 seconds. The second ablation site was located at the pericaval portion, a little upper. And the patient take the contrast-enhanced ultrasound at the first day after ablation. We can see the whole caudate lobe no enhanced, and from right side, the caudate lobe no enhanced. 2 months later, the patient take the contrast-enhanced CT. We can see from top to the bottom, the whole caudate lobe no enhanced. From March 2018 to December 2019, 8 patients with HCC located at caudate lobe were treated through this procedure in our center. So this is the patient general information. And most patients are male, and the 2 patients had multiple lesions. This is the ablation parameter. The diameter of lesion from 1.6 centimeter to 3.2 centimeter. All patients has multiple ablation sites, so we have to reinsert the antenna in the procedure. Only 1 patient punctured through right side, and only 1 patient used a single antenna. Most patients used the 5 millimeter tips. The outcome, all the procedure was success. The median follow-up time is 10 months. Until now, no patient died and no local tumor progression. 1 patient had intrahepatic recurrence, And complication, two patients had hemorrhage stopped by ablation in procedure, and one patient had right pleural effusion. This is case 2. A male patient, 48 years old, take one-time ablation treatment for HCC 1 year ago and two-time TACE treatment 1 month ago. This, the CHE is decreased. This patient PLT decreased seriously, and PT prolonged, PTA decreased, AFP a little high. So this is the patient's MRI. We can see the lesion located at in the caudate lobe. And tumor diameter is about 2.7 centimeter. This is the first time the ablation area. This is the fusion images. We can see the tumor is here. Through left lobe, the tumor display clearly. This lesion take two-time TACE treatment, and the patient taken chest enhanced ultrasound. We can see the tumor still have artery supply. First, we insert two antenna through left side into the caudate lobe, guided by fusion images, and then we use a single antenna through the right side. So we show this procedure in an international training program at last year, and 2 months later, the patient taken chest enhanced CT. We can see the whole caudate lobe, no enhanced. This is a special patient. This patient HBV positive, and liver function, blood routine is normal, and AFP is very high, more than 1,000. This patient has a very big tumor in the right lobe. Here, the tumor in the right lobe. After the MDT, the patient take the hepatectomy. Pathology, moderately and poorly differentiated HCC. After the operation, the patient take two-time TACE treatment, and no finding on CT, and the AFP decreased but not normal. 6 months later after the operation, the patient recurrence. AFP is still a little high. There was 3 lesions on CT. The first lesion is near the diaphragm. The second lesion located in the caudate lobe. The third lesion we think is peritoneum metastasis. So for this patient, after the MDT, the patient chose the ablation treatment. Because this lesion is small, mainly in the pericaval portion. So our plan is not ablate the whole caudate lobe. We plan to ablate the pericaval portion and the caudate process. So this patient, we use a single antenna, and we punctured only from the right side. Parameter, first we ablate 2 sides. We use single antenna. The 5 millimeter tips, power is 65 watt. After that, we take the patient take the contrast enhanced ultrasound. We can see the necrosis area is small. So 3 additional ablation sites at the upper part of the lesion was taken. And then the second tumor near the diaphragm, we use single antenna. Tip is 11 millimeter. Power is 55 watt. a single site. Time is 3 minutes. And the third lesion located in the, I think it's peritoneum metastasis. We use fusion images guided to ablate. Also single antenna tips 11 millimeter. Power is 55 watt. And 2 months later, the contrast enhanced CT. From the top to bottom, we can see the paraclaval portion and caudate process is no enhanced, but spegal part, specal lobe is still enhanced. The lesion near the diaphragm are no enhanced, and the peritoneum metastasis disappear. And the patient's AFP decreased to normal. 6 months later, the ablation area shrink, becomes small, and no recurrence. AFP is still normal. And 1 year later, the patient recurrence the second time. The new lesion is located in the segment 7. And the 3 lesion we ablated is still stable, no recurrence. So next, the patient take the targeted drug, take the systematic therapy. Summarize. Fusion images guided microwave ablation of whole caudate lobe could be a safe, feasible, and effective treatment for HCC in caudate lobe. Second, a whole caudate lobe ablation can effectively reduce the local tumor progression rate. Fusion images can better show the anatomical relationship between the lesion and hilar and improve the safety and effectiveness of ablation. The limitation of this study, the sample size is small and the follow-up time is short. Thank you. Here is my email.